Greetings, pharmacology students, and welcome to week 5. We're going to hit on drugs that act on the cardiovascular system, including blood pressure medications, a huge part of pharmacology, and drug administration when it comes to a hospital setting as well, and also drugs that work on the renal system. Those kind of go hand in hand. If you imagine that diuretics are the major group of renal drugs that we give. We also give those, of course, for hypertension. This week you have a VSIM due. It is scenario number 10 on the patient named Rachel Heidebrink. This is drugs acting on the cardiovascular system. So chapter 42 is an introduction to the cardiovascular system. You are all paramedics and LPNs. I'm assuming that you have working knowledge of the cardiovascular system. Look at that chapter yourself. See if there's anything you need to refresh yourself on. What I want you to take away from that chapter as you say, no, I know this, is you need to be able to label, for instance, the parts of the heart. If you had a diagram of the heart, would you be able to name the chambers, name the valves, etc., the coronary arteries, and know a general idea of what the conduction system is. Also describe the blood flow through the heart. You should know the general components of a normal EKG. One of your objectives is to identify a variety of arrhythmias. I'm telling you right now that we're not going to focus on dysrhythmias of the heart because we're also, right now you can cross out chapter 45. We're not going to really hit on the antiarrhythmic drugs. You will hit this more intensively when you go through block 4. I want you to know what atrial fib is. And we are going to talk about medications that people are on when they have AFib. And then what is a lethal ventricular arrhythmia, for instance. A review here, this is one of my favorite things, so I tend to hit on it heavily, is the renin-angiotensin system. Sometimes it's called the renin-angiotensin-aldosterone system, or the RAS, or the RAAS. If you understand this, and I actually put a diagram, a JPEG, up in Canvas for week 4 for you to look at. I would love it if you would print that out. It's in color. Put it in a page protector. Sleep with it under your pillow. Keep it with you always as you go through nursing school. Because if you have incorporated what that system is into your brain, it's going to help you in so many ways. When you get to the endocrine system, when you study liver disease, it's just understanding that system. It affects so much, but it is at the core also of what regulates our blood pressure, hypertension, hypohypertension. So I do want you to have read about that because it'll hit you again in a couple chapters. They'll refer to it. So if you don't know what I'm talking about, or you're kind of scratching your head like, yeah, something about this makes this happen, read about it in this chapter 42, which is a good explanation of it. Okay, moving on to chapter 43, drugs affecting blood pressure. This is probably your biggest chapter with the most content that I think it's important for you to know. What controls the blood pressure? And again, refer back to that diagram. What are the elements that control blood pressure? You know, the heart rate and the stroke volume and the peripheral vascular resistance. So read all about that. Again, in this chapter, it hits on the renin-angiotensin-aldosterone system. The severity of, what is hypertension as far as the numbers? Do you know what the numbers are? And that's kind of a moving target these days. Every 6 months or so, it seems like either the American Heart Association or the AMA come out with new guidelines for what hypertension is. Actually, they reduced it about 2 or 3 years ago, and then just recently I heard, I haven't seen it, but I heard it, that on TV that they've raised it up just a little bit. I think there's a fear that if they make the guidelines for definition of hypertension too low, that people will actually end up being over-medicated, or a certain population of patients will end up being over-medicated. But you need to know from this chapter, what are the risks of hypertension? And I can tell you right now, you'll read about this as well, but diabetes and hypertension are the number one and number two causes of renal failure. So right there, that's a huge risk. And we're talking about chronic renal failure, not acute renal failure, but chronic renal failure that ends up in what we call end-stage renal disease, ends up with patients on dialysis or dead. What is our approach to treating hypertension? What are the cultural considerations related to hypertension? And this is important because there are certain populations where, for instance, African Americans, where hypertension has a greater prevalence. And because of that, all these other things, if hypertension has a greater prevalence, so does diabetes, so does renal disease. So read about the cultural considerations for hypertension. And then what's our systematic approach? Obviously, dietary approach is one. When you look at what the risk factors are, you try to eliminate some of those risk factors that you can control versus those that you can't. There's something called essential hypertension, which is basically you may not have any of the risk factors that we think of as causes for hypertension, and yet you still are hypertensive. So we need to start treating you with medications. Typically, you just layer one medication on another medication on another medication until you get the desired effect. So I want you to read about these various categories of medications and combinations that we use to treat hypertension. One is obviously diuretics. And you're going to read a little bit about diuretics in this chapter, but again, you're going to read in chapter 51 at the very end of this more about the effects of diuretics. Diuretics, in that will just draw some extra fluid off, will reduce the workload of the heart, increase the oxygenation of the heart by reducing that workload. And then first class of medication that we'll start to use with someone who's been diagnosed with hypertension is the ACE inhibitors. The ACE inhibitors, those are the PRILs, the PRILS drugs, like lisinopril. I want you to look up lisinopril because that's probably the most popular of all the ACE inhibitors. So ACE inhibitors, angiotensin converting enzyme inhibitor. So go to this diagram I asked you to print out and look to see where you think an ACE inhibitor would actually be working, okay? And remember, ACE inhibitors are number one along with diuretics to start treating hypertension. Another class of medications that may be used are the angiotensin II receptor blockers. Those are the sartans. So if you look at the beginning of this chapter and look at the drug list, you'll see that all the ACE inhibitors end in PRIL. You'll see that all of the angiotensin II receptor blockers, or the ARBs, the ARBs, they end in sartan. Now look at your diagram again that I asked you to print out, and where do you think angiotensin II, first of all, when we talk about angiotensin, I don't think it's apparent, well, it might be in that diagram, but there's angiotensin 1 converts to angiotensin 2. Angiotensin 1 has really no effect. Angiotensin 2 is the effective substance. So it's angiotensin 2 receptor blockers that could help to reduce blood pressure. But I'm telling you this right now, you'll never have a patient that's on an ACE inhibitor and an angiotensin 2 receptor blocker, because the end result is the same. You'd be kind of double dosing that patient with, yes, they're two different classes, but the angiotensin 2 receptor blockers are for people who cannot tolerate the ACE inhibitors. And you're going to know who those people are and what that looks like, because you're going to read about what are the nursing considerations, what are the patient teaching points when we put a patient on an ACE inhibitor. It's not for everyone. So if you can't tolerate an ACE inhibitor, then your doctor's going to put you on an angiotensin 2 receptor blocker or an ARB drug that ends in sartan. Okay? Then if we're still not getting the right effect, we're going to layer on possibly another category of medication called a calcium channel blocker. Those are the dipines, D-I-P-I-N-E-S, the end in dipine. Again, look back at the front of this chapter, look at your drug list, and you'll see the dipines. And then there's another category of vasodilator, but we use those vasodilators more on an emergent basis. So as far as drugs for the ACE inhibitors, I want you to read about lisinopril. As far as the ARBs go, I want you to read about losartan. The calcium channel blockers, read about diltiazem. And for the vasodilators, read about nitroprusside. Again, the nursing considerations and the teaching points. So of all those different categories, I've given you one drug to really focus in on those. But know that if you can teach yourself about how the classifications are named, that you're taking a test question, for instance, and it says the patient's been placed on captopril. You're going to go, pril, that's an ACE inhibitor. So you're going to know, even though it's not the drug I told you to look up, you're going to know it's a pril, and it has the same capabilities, the same expectations, and the same side effects. Going on to chapter 44, agents that treat heart failure. You're going to review what congestive heart failure is. So some texts still call it congestive heart failure. I think this one does. Other texts just call it heart failure, or HF. And what are the causes of heart failure? And guess what? You're going to end up going back to that diagram again, that RAAS diagram when we talk about heart failure. Because what's important for us to remember about heart failure is the compensatory mechanism that kicks in automatically when we start going into heart failure. Read about it, look at that diagram, and you will deduce, I believe, that unfortunately the compensatory mechanisms that kick in when we start going into heart failure only make it worse. So this is kind of a situation where our compensatory mechanism that we're born with backfires. And what it's trying to help us is really just making things worse. One of the complications of heart failure is cardiomegaly, and that is when the heart starts to actually enlarge. And as it enlarges, it obviously is going to beat less effectively, pump less effectively. It affects the conduction, the electrical conduction of the heart, because as those heart fibers start to stretch, the electrical paths might be detoured in some way, or at least slowed, as there's like more road for the electrical path to actually follow. There's many classifications of drugs that your book lists that are treatments for heart failure, but I'm going to focus on the most popular, the mainstay for treatment of heart failure, which is digoxin, and that's considered a cardiac glycoside. The reason we're going to focus on digoxin is because there's a lot to know about digoxin, and one is the signs of dig toxicity. How does that happen? There is a critical thinking scenario in this chapter 44 that I want you to look over, and it's about a patient who has been on dig for about 10 years and then changes their lifestyle. They go into an extended care facility or whatever, and suddenly they're getting digoxin a different way. So I want you to read about that and then focus on the teaching points for someone. There's another big box, it's blue, called nursing considerations for patients who are basically put on digoxin. So those are important things for you to pay attention to. Chapter 45, the antiarrhythmic drugs, just kind of skim right over that. I'm not assigning any reading or any drugs. You know, in a way, we can kind of think as of digoxin as an antiarrhythmic in some way, because many patients who have atrial fib are actually on digoxin. So go to chapter 46, which is the anti-anginal agents, or anti-anginal, depending on your pronunciation, agents. This will give you an overview of coronary artery disease. Actually, coronary artery disease is one cause of congestive heart failure. If you have had an MI, you're at risk for developing heart failure. The goal of our pharmacological intervention when it comes to heart failure patients is to reduce the myocardial oxygen demand to reduce the workload of the heart. So the categories of medication that we use to treat angina are, again, at the top of this chapter is a drug list with the various classifications. I want you to look at the nitroglycerins. Look at nitroglycerin, the sublingual, for instance, nitroglycerin that you're probably familiar with. Isosorbides is in the nitroglycerin group as well. Beta blockers are used here. And recall that we didn't really talk about beta blockers when we were talking about treatment of hypertension. And that's because all those other categories of medications that I gave you are much more effective. It doesn't mean that you won't have a patient who's on some of those as well as a beta blocker, but chances are the patient got on that beta blocker later. Something happened, or they're referred to a cardiologist, and the cardiologist is going to try to tweak things a little bit. It's not that frequently that a nurse practitioner or a family practice doctor will give the patient a diuretic, an ACE inhibitor, calcium channel blocker, and a beta blocker. Those beta blockers are for people with more complex hypertension and evidence of heart disease. So the beta blocker I want you to look at is metoprolol. And then these are the OLs. Remember, beta blockers and then the OLs. So if you can remember metoprolol, then you'll be fine with atenolol, etc. And another category that's used for patients with heart failure are the calcium channel blockers. And you can look up the drug diltiazem as your calcium channel blocker in this chapter. Again, we're looking at the nursing considerations, the patient teaching points for patients who are put on these medications. Chapter 47 is the lipid-lowering agents or the anti-cholesterol agents. As you read this chapter, you should be focusing on hyperlipidemia as a risk factor. How does hyperlipidemia link to coronary artery disease? How do the lipids make their way into the coronary arteries? The truth is, they just don't make their way into the coronary arteries. But that's what we're focusing on. They're probably, the lipids are in your carotid arteries as well. Sometimes you've got lipid or plaques in your aorta. So we're focusing on coronary arteries. Know that hyperlipidemia is not selective to find its way to the coronary arteries, but that's where it causes problems for us, or the most problems for us. So you'll read about what are the modifiable risk factors versus the unmodifiable risk factors. And we do know that there's different kinds of cholesterol, the good cholesterol, the bad cholesterol, and that sometimes people are simply genetically predisposed to a higher lipid content, and it has to do with what is their liver up to. One of the questions I was going to throw at you is, why do we teach patients to take their anti-lipid medication at night? During sleep, your body gets busy, your liver gets busy making cholesterol, and the anti-lipid medications, most of them have a half-life of 12 to 14 hours. So they're probably most effective in the first half of that 24-hour cycle. For this group of medications, I want you to look at atorvastatin. These are all the statin drugs, S-T-A-T-I-N, statin drugs. These are your anti-cholesterol drugs. So atorvastatin is probably the most popular. It is Lipitor. Again, the nursing considerations, the patient teaching about these kinds of medications. Then we're going on to chapter 48, drugs affecting blood coagulation. This is a little intense because it has to do with the coagulation cascade or the blood clotting cascade. I got excited because in the top of this chapter there was an animation, and I'm like, oh, this will be good, a really good animation. I'm your instructor. The animation went like this, whoop, over my head. Take a look at it, see if it helps you at all. There's a lot of substances that are referred to in this very short little video that we really, I want to say, we don't need to know about as nurses. The clotting cascade is complex, even without all these other substances that are mentioned in this animation. but I'm going to give you some categories that we're going to focus on. One is the antiplatelet drugs. So again, at the top of this chapter, there is a drug list with these various categories. So for antiplatelet drugs, I want you to look at aspirin and Plavix. Aspirin and Plavix. Now, generic for Plavix is clopidogrel. So it's on your list as clopidogrel, CLO. So in the antiplatelet group, aspirin and Plavix. Know that when you see a drug or when you learn about a drug that's an antiplatelet, and you'll get this in your reading, it doesn't mean that it affects the production of platelets. You know, all of our blood cells come from our bone marrow. It doesn't affect the production of platelets. It affects the effectiveness of platelets, and it prevents them from doing what they want to do most. So aspirin has a low-grade effect on platelets like this, Plavix much more. Plavix, and then all the other ones you see on TV, again, these are for people who, like if you have a stent, for instance, you're probably going to be on Plavix for 6 months or so after you have a cardiac stent put in one of your coronary arteries. And I used to tell patients that because a stent is a foreign object and your blood's, you know, streaming through that coronary artery 24/7, and the platelets are going to stop and be curious about any kind of a foreign object, this medication just makes your blood a little more slickery, and it keeps those curious platelets just floating by instead of clumping up around and actually causing a clot around the site of the stent. So that's your antiplatelet group. Again, does not affect production, but does affect the action of the platelets. Then the anticoagulant therapy group, two drugs that I want you to look at there are heparin and warfarin. Warfarin, also Coumadin, same thing. Warfarin is the generic name, Coumadin is the brand name, but all those patients who have atrial fib that are on DIG, very many of them are on warfarin as well. Again, because that ineffective pumping of the heart that you get with atrial fib causes there to be residual backflow, especially in the ventricles. So the ventricles do not empty efficiently or sufficiently. So anytime there is a chance for stagnation of blood, there's a chance for clots to start forming. That's why atrial fibrillation equals Coumadin, or again, something like it, something you see on TV. But those are drugs that are going to prevent blood clots from forming, hopefully in this case in the heart. So to heparin, we use heparin for we're treating patients with a DVT or deep vein thrombosis. We treat patients with pulmonary embolism with heparin. But we also give low molecular weight heparin to many, many, many people in the hospital as kind of a prophylactic to the development of blood clots. And that drug that I want you to look up is Lovenox. The generic name is enoxaparin, E-N-O-X, enoxaparin, or Lovenox. So read about the half-life of Lovenox and the patient teaching that we're going to give a patient on Lovenox. There's a classic NCLEX question that has to do with a patient who is on Lovenox and then is put on Coumadin. What is the proper action for the nurse? And one of the answers is, you know, refuse to give it, call the doctor, da-da-da-da-da. Know that when you read about Coumadin, you'll read that, or you'll be reminded, you may already know, that Coumadin doesn't act today. I take Coumadin on Monday, there's no effect. I take it on Tuesday, there's still no effect. I take it on Wednesday, there's starting to be an effect, and I'm probably not going to be therapeutic in my Coumadin or warfarin effect until, and we'll know this by blood tests, until Thursday, possibly Friday. And that is because of how and where Coumadin works along that clotting cascade. So read about that. And so is it, what is the correct answer to this question? Well, sometimes we will need to provide the patient, as we're putting them on Coumadin, we want them to take Coumadin every day, but we know that it's not working on Monday, Tuesday, Wednesday, or possibly Thursday. We're going to give that patient Lovenox on Monday, on Tuesday, on Wednesday. We might send them home with a few doses of Lovenox because we want them to have the protection of that anticoagulant agent, and we know that the Coumadin takes a while to kick in. Same thing when you're coming off of Coumadin, we might put the patient on what we call a Lovenox bridge because it's going to take a while for the effect of Coumadin to wear off when we're getting ready to send a patient to surgery, for instance. So read about enoxaparin. And then the other group in this chapter are the thrombolytic agents. You can read about one medication called Alteplase, and we also know that as TPA, and that is what I call the clot-busting medication that we will give intravenously for someone who's had a thrombotic stroke. We've done a CT scan, we see that they're not hemorrhaging, but their stroke was caused by a blood clot. If we get to them fast enough, times are changing, but I think that 4-hour mark is still the drop dead time, that the symptoms, from the time of the onset of symptoms to the time of therapy, we can start running that TPA within a 4-hour period. And then I do want you to read about what is the role of vitamin K. And again, this has to do with the clotting cascade. What is the role in vitamin K in when we're treating patients that are on medications like this? So you're looking at the nursing considerations for these drugs that I've mentioned and the patient teaching points. Then chapter 49 is drugs to treat anemia. We're only going to touch on a couple in this chapter. You should know what the components of blood are because this chapter will review that for you. But when we're talking about anemia, we're talking about a shortage of red blood cells for whatever reason. We're bleeding them out somewhere, possibly slowly, like a GI bleed, or we're underproducing them because there might be a defect in our bone marrow somewhere, so we're underproducing the red blood cells, or there's a red blood cell deficiency that is causing them to not live their full life. They're dying off too quickly. All of those are possible causes of anemia, as well as some dietary deficiencies. So the drugs I want you to look at in this chapter are what we call EPO. This is what Lance Armstrong and I guess the whole entire Russian Olympic team in Sochi used to dope, they call it, is to boost their production of red blood cells artificially, but it works. We also give EPO to cancer patients who are undergoing chemotherapy or radiation therapy, anything that's affecting their production of red blood cells. We'll give them EPO or Epotin to boost their production of red blood cells. For athletes, obviously it increases their oxygen carrying capacity. So they're going to run faster, jump higher, etc., kind of be superhumans. But it's frowned upon. In any competitive sport, EPO is illegal. That's why they blood test those athletes. So do an overview of the erythropoietins. We call them this category, but we call, the drug that we use is Epogen or Epogen alpha. Also look at iron, folate or folic acid, and vitamin B12. What is the role of those three nutrition components as far as the production of red blood cells? And then if we have a deficiency of iron or folic acid or B12, what is the likely result? There is always an NCLEX question about the administration. You're in a hospital or you're sending somebody home who's going to be on iron preparations for whatever. If you give IV iron in the hospital, it's called ferrous sulfate, I think. I'm a little fuzzy, but what I know is it's licorice colored. It is brown, and you usually hang it in a piggyback, and if you get it on you, it stains. If you give someone an injection of it, this is where we use the Z-Track method of injection, where we pull the skin over, inject. This is so that we don't stain the patient's skin. Well, imagine if it's an oral preparation, there's the chance that you'll be staining the patient's teeth if you do not give proper instructions. So read about patient teaching when it comes to iron preparations. It'll have to do with the position they're in, sitting, lying. Like if you have a patient in a bed at the hospital, you just read about it. You need to sit them up, etc. Whether they're to take this on an empty stomach, a full stomach. So there will be an NCLEX question in your future about the proper way to teach a patient about iron preparations. Chapter 50 is Introduction to the Renal System. So this is an overview of basically the kidneys and the bladder, the urinary tract. So you look at this chapter as you need it. And guess what they refer to? Again, in this chapter, the renin, angiotensin, aldosterone system, because renin is a hormone secreted by the kidneys. And if you look back at that diagram, it'll remind you of that. So just look at that chapter as you need to review. And chapter 51 is diuretics. There are different categories of diuretics, but in this chapter I want you to look at one example of a thiazide diuretic, which is HCTZ or hydrochlorothiazide. Hydrochlorothiazide, it's very popular. And another medication to look at is furosemide, which is Lasix. This is also very popular. Where does Lasix work? Spironolactone is a potassium-sparing diuretic. So where most diuretics cause you to lose potassium, so that puts the patient at risk for hypokalemia, spironolactone is a potassium-sparing diuretic. So read about that one. And then also mannitol as an osmotic diuretic, not so much for the treatment of blood pressure. We think of mannitol for patients with cerebral edema or head trauma, etc. So look at those specific diuretics. You can skip over chapter 52. So put a stroke through chapter 45, which is the antiarrhythmic agents. Put a stroke through chapter 52, which is drugs affecting urinary tract and bladder. Don't forget to do your VSIM, scenario 10, your weekly quiz, and then your midterm, which is 40 questions. It opens next Sunday, closes next Tuesday at 10 p.m. Refer to your syllabus and your course schedule under your syllabus, also on Canvas, to remind yourselves of those times. Please budget some time to do that. So you're going to have a quiet area, a quiet, uninterrupted time. You'll have 40 minutes to answer these 40 questions. Give me an email if you have questions about anything. Thanks.